Day to you, wherever you are. Welcome to another session on manual therapy lectures. My name is still remain Professor Oluwaleke Shokunbi. Today we want to talk about introduction to serious techniques in manual therapy. Introduction to serious technique in manual therapy. Our lesson objectives will be to understand the principle of management, the principle of managing a patient with serious technique, possible source of lesions that are amenable to serious technique, principle of assessment in using serious technique, and the technique of treatments as applicable in serious technique. Now let's talk about the principle of using serious technique method of manual therapy. One of the principles is that all the pain that you want to treat with serious technique must arise from a lesion. So it doesn't treat psychogenic pain or psychiatric pain. The pain must have an identifiable sources of lesion, and that the treatment you are carrying out must be directed to the lesion, and it must reach the affected side. And the third principle is that all the treatment must exert a beneficial effect to the affected side. If it doesn't causes any beneficial effect, then there's no point in using serious technique, right? Now, what are the possible of lesions, that will be treatable or amenable to serious method of treatment? Well, any lesion that comes from contractile structures, lesions that come from non-contractile structures, any lesion that come from the joint, or what we can call articular lesions. Then the rest of the sources of lesion are categorized as other sources of lesion. We're going to talk in detail about this in a short while. What do we exactly mean by contractile and non-contractile will be addressed very shortly. Now, under the principle of assessments with serious method of treatment, you see every school of thought as what they emphasized in assessments, just like Mackenzie emphasized mechanical type of pain, end of range pain, repeated movement test. Cyriax also emphasizes the use of active range of motion, the use of passive range of motion, and the use of resisted active range of motion during assessments. And generally, his method of assessment is referred to as selective tension method of assessment. Okay, active range of motions are movements that are carried out by the muscle and the tendon attached to the bone. And it takes note of capsular or non-capsular pattern during this active range of movements. I'm going to explain the capsular and the non-capsular components in a very short while. And when the resisted active range of motion is happening, that's when the therapists apply a direct resistance on the action of the muscle in an isometric pattern. And whenever pain is aggravated, it also confirms involvement of contractile tissue. We're going to talk about this very shortly. Then with passive range of motion, the patient is the one carrying out the movement by themselves. And then there's a way the therapist, no, in the passive range of motion, the therapist are the one carrying out the movement for the patient. And there's something that the therapist will feel in his hand at the end of the movement, which is called hand feel. And that is what Cyriax wants the therapist to take note of while using this method of patient management. Now, I want to talk a bit more about the selective tension approach to assessment as advocated by Cyriax, and that is to say that active movements are used to assess lesion in the contractile structure. When we say a structure is a contractile structure, it means the structure can contract on its own and generate tension. And a very good example of this is muscles, muscles in our body and the tendon to which they are attached. Muscle and tendon can contract and exert tension to cause movement or to stabilize a joint. So if there's a problem in muscle and tendon, When you cause them to contract, then the pain or the lesion will increase because that will put more demand on the normal work they're doing. Or if you apply resistance on the action of that muscle and tendon, then the pain or the discomfort that the patient is feeling will increase. So that's how Cyriax dictates problem in the contractile structures. It will make them to contract, do their normal action, and if the pain or the discomfort increases, then most likely the lesion is coming from the contractile structure. Then we have passive movement. So passive movement tests are usually used to diagnose lesion in the non-contractile structure, which are also called the inert structures, like the ligaments. The ligaments ordinarily will not contract unless they are stretched to the limit of their extent. Then they do passive tension, but they don't contract. So if you carry out passive movements on a patient and you get to the end of the range and the discomfort increases, then it is very likely that the problem or the lesion is coming from the non-contractile structure. And there is also something that Cyriax called capsular pattern, which is a pattern of movement detected by lesion in the joint capsule. And capsule is only found around the joints. So if you carried out either active or passive movement and you notice a pattern of movement restriction that we can call capsular pattern, it only shows that the problem might not really be in the capsular or not capsular, but rather inside the joint. It's only when the problem is articular or is coming from the joint, that's when you notice a capsular pattern of movement. There could also be a situation whereby there's internal derangement or internal impingement, something present very close to a joint affecting the normal positioning of the joints or the normal movement of the joints inside the body. That's what we call impingement. So if something like that is present inside the body, how do we diagnose them? Then Cyriax advocates the use of hand feel, because moving every joint to the end passively should produce characteristic impact in the hand of the patient, which we know to be normal. So if you don't get that normal end feel, you get an abnormal end feel, and the presence of abnormal end feel is an indication that there is an impingement inside the body. So basically, selective tension method of assessment of Cyriax utilizes active movement, passive movement, resisted movement, and capsular pattern as well as end field to make diagnosis in different structure that could be responsible for patient pain. Right here you have the list of structures in the body that could be classified as either contractile or non contractile. Joint capsule, yes, that will be a non-contractile or inner structure because it cannot contract to generate tension. So also ligaments, bursae, sometimes they are classified as contractile, sometimes non-contractile. Aponeurosis, dura mater, peripheral nerves, all these structures listed there, they lack the ability to contract and generate tension, so they are called inert structures, and problems or lesions in them will most likely be detected by using passive movements. All right, whereas if you look on the right hand side, you're going to see the muscle belly. All right, then where the muscle is attached to the tendon is musculotendinous junction. Then the tendon itself, and where the tendon is attached to the bone, you can have muscle bone attachment. All these areas of the body can contract to generate tension. So they are all known as contractile structure. How did Cyriax said we should identify problem in the contractile structure again? Make them to contract and to carry out the action, and if the discomfort increases, you suspect contractile structure, or you put resistance, isometric resistance on the action of that muscle and tendon, and if the discomfort increases, you know to a high likelihood that lesion is in the contractile structure. Okay, now Cyriax went ahead to demonstrate contractile, non-contractile method of assessing contractile or of assessing problem within the contractile and non-contractile tissue, with the use of shoulder and rotator cuff impingement, which we are going to talk about very briefly. But don't forget what I said, that when you carry out an active movement and the severity of the symptoms increases, that could be due to problem in the contractile structure. For example, in the diagram we have here, if you ask this patient to do abduction, as the patient is doing the abduction, the pain in the shoulder is increasing, it's most likely that the problem is coming from the muscle that is contracting to carry out abduction. If you ask patient to do shoulder flexion and the pain and discomfort increases, it is very likely that the problem is coming from the muscle that is responsible for flexion movement, something like that. But if on the other hand, a passive movement is carried out for flexion, and at the end of range of flexion, that's when the patient feels the discomfort, then it could be the ligaments that are attached to the body to restrain that movement of flexion that is actually having lesion. So lesion generally in contractile structure can come when the contractile structure contracts, or when resistance in form of isometric contraction is put on the contractile structure, or when the contractile structure is stretched in the opposite direction to shortening if there is any adhesion. And for the non-contractile structure, it's quite easy. The lesion within non-contractile structure like ligament, like bursae, they usually detected with Cyriax technique by using passive movements. All right, passive movement to the end of range will stimulate the pain or discomfort in non-contractile structure. Take for instance, when we're doing valgus and varus stress test in the collateral ligament of the knee joint, you'll recall that the ligament is a non-contractile structure, and before you can detect any lesion in the medial collateral ligament, for example, then you will need to apply a valgus stress test, isn't it? What is valgus stress test? It's just moving the tibia part of the leg outwardly while maintaining the thigh part of the leg inwardly. That will put a stretch. The passive movement will put a stretch on the medial collateral ligament, and you know straight away that the pain is not in the muscle. It's more likely to come from the medial collateral ligament. So lesion in the non-contractile structure generally are detected using passive movement, right? Like I said earlier on, Cyriax went further on to illustrate this principle of selective tension in rotator cuff muscle impingement, or what some people will call supraspinatus impingement. I have explained to you earlier on that impingement is otherwisely a situation whereby something is blocking the normal position of the joint or the normal anatomical movement of the joint inside the body. So if you have something existing in the body, like cartilage, calcific tendon, or something that is not part of the body, that forms pathologically and is now blocking the alignment, is altering the normal alignment of the joint, or blocking the normal anatomical movement of the joint, that will be called an impingement. And such could happen during rotator cuff impingement. The first attempt Cyriax advocated to notice problem with rotator cuff impingement, ask them to do active movements, say active abduction to elevation or active flexion to elevation. And if you ask a patient that have rotator cuff impingement to carry out active abduction to elevation of 180 degrees, what you might notice is that one of the possible outcomes is that the patient will demonstrate discomfort or report pain when it gets to about 45 to 60 degrees of abduction, and the pain or discomfort continues until it gets to 120 degrees of abduction, and then by the time it gets 120, the pain eases off until the end. Or it could be that the pain will not even feature between 45 and 120. The pain will only get reproduced when the patient gets to 170 degree. So what's the meaning of all this? If you have a patient that demonstrated pain or discomfort between 45 and 120 degree of abduction, active abduction, because it's active movement, based on Cyriax approach, we suspect contractile structure. So what contractile structure could be responsible for that? We suspect the rotator cuff muscles, because they are the one whose action is to, they all have role to play in carrying out such a movement. So if you ask a patient to carry out abduction, active abduction, and pain comes between 60 and 120 degrees, you begin to query involvement of the rotator cuff muscles. Which one of them in particular, this test would not tell us, but it just tells us generally that painful arc syndrome test, that's the name of the test, is an indication that something is wrong with rotator cuff muscle whenever such test is positive. And when is the test positive? When there's pain between 45 and 120 degree of abduction going to elevation. But you will remember I did mention the other time that it's possible that with some patients, they will not even have pain between 60 120. Their pain only gets on when they are approaching the end of elevation between 170 and 180 degree. And at that point, there is only one joint around the shoulder which could be compressed upon, and that is acromioclavicular joint. So if the pain comes up between 170 and 180 degree, you can confidently, to a reasonable extent, diagnose lesion in the acromioclavicular joint. So if the pain is produced during active movements between the angle of 60 to 120, you can suspect rotator cuff lesion or tendinitis, including subacromial bursitis. But if the pain comes between 170 and 180, you'll likely suspect acromioclavicular joint arthropathy. So painful arc syndrome tells us that something could be wrong with the rotator cuff muscles, but it didn't tell us which one of them in particular. In the rotator cuff muscle family, we have the supraspinatus, the infraspinatus, the subscapularis, and the teres minor. How do we know which one of them is affected? Although PAS test has told us there could be problem in each one of them. Well, the next thing to do is to put resistance on the action of each of the muscles, and if the pain or discomfort increases after putting resistance on each of the action of the muscle, then you definitely know that that muscle is involved. That's why you have on the diagram on the left hand side, the most left hand-sided diagram here, where supraspinatus is written. The therapist is putting resistance on supraspinatus after painful arc syndrome has turned positive, and if that reproduces the pain of the patient at the shoulder, that's an indication that supraspinatus is involved. The action of supraspinatus is abduction, so the therapist is actually putting resistance on abduction from about 18 to 20 degrees from the body, and if that reproduces the pain at the shoulder, then that means supraspinatus is actually involved in the pathology of the shoulder joint. Then in the top middle diagram, you have the therapist applying resistance to internal rotation of the shoulder. So therapist is trying to resist the patient from bringing the palm to the belly button or to the stomach. So just to the abdomen, is preventing the patient from bringing the palm to the abdomen or to the belly button. So if that resistance is applied, it's going to affect the subscapularis muscles because it's the main internal rotator of the shoulder. In the top right diagram, we have the therapist applying resistance to external rotation of the shoulder. And if the pain in the shoulder is reproduced as a result of this maneuver, then we know that there could be a problem with infraspinatus and teres minor. So that's how resistance will be put on all the rotator cuff muscle components in order to know which one of them is contributing to the pain that is coming with painful arc syndrome. If the shoulder pain is reproduced with abduction, then supraspinatus will be implicated. If the shoulder pain is reproduced with internal rotation resistance, isometric resistance, then that shows that subscapularis is implicated. If the pain is reproduced with infraspinatus isometric muscle resistance, then that shows that if external rotation, isometric resistance reproduces the pain in the shoulder, then that's an indication that infraspinatus and teres minor are implicated. And if bicep femoris is involved, because sometimes bicep femoris, though is not a component of rotor cuff muscles, but it could reproduce a pain going to the shoulder. So how do we know that? How do we screen bicep femoris involvement apart from aside from the rotor cuff impingement? Then we have to carry out a test known as Yagerson test. How is Yagerson test carried out? You get the patient seated or standing, the elbow will be in extension and pronation. It will be in extension and pronation. So the patient will have to carry out a movement which is flexion and supination of the elbow against the resistance of the therapist. So while the patient is trying to do flexion and supination, if the pain is reproduced at the shoulder, or if there's a clunk sound, a click sound underneath the finger of the therapist that is lying directly over the shoulder, then that's an indication that bicep femoris is involved. And that's what Cyriax said by saying that lesion in the contractile structures can be diagnosed by using active movement and resisted active movement. Active movement was used in the first instance when patient was asked to do abduction to elevation, and the painful arc syndrome test was positive. We know that contractile elements of rotor cuffs are involved, but which one of them specifically, resisted isometric muscle exercise, will have to be carried out as just being described. All right, so what if the lesion is coming from the joints? How do we know? Then that is where Cyriax advocated the use of capsular pattern in the assessment. So beside contractile active movements and resisted active movements, another technique of assessment is to take note of the capsular pattern. So what do we call capsular pattern? Capsular pattern is the pattern of movement restriction in the range of motion that is caused by abnormality in the joint capsule, maybe tightness or inflammation of the joint capsule. All right, whenever the joint capsule in any joint is affected in form of tightness or inflammation, it will always produce a characteristic pattern that can be identified by any therapist. If the joint in the neck, if the joint capsule in the neck is affected, it will come up with a pattern. If the joint capsule in the shoulder is affected, it will come up with a pattern. And that pattern of movement restriction is what is known as capsular pattern. Anywhere capsular pattern is spotted by a therapist using Cyriax technique, it is an indication that it could be an indication of degenerative changes in that joint, or what people call osteoarthritis, because whenever there's osteoarthritis in the advanced stage especially, it will affect the joint capsule. So anywhere capsular pattern is spotted, it could be an indication of capsulitis in isolation, or it could be an indication of osteoarthritis or spondylosis in general. I hope that is very clear. And this table here is just illustrating different form of movement that happen that could make you to conclude about capsular pattern happening in different parts of the body. For example, in the cervical spine, if there is capsular pattern, the joint capsule is involved, the moment you ask the patient to do the normal physiological movement in the cervical spine, which are what? Which are flexion, extension, side flexion, and rotation. The moment you ask the patient to do this, and you notice that side flexion on the right is equal to side flexion on the left, and you notice that rotation on the right is equal to rotation on the left, you know that you are having a capsular pattern, regardless of what happened to other movements. As long as side flexion on the right and side flexion on the right are equal, or rotation on the right is equal to rotation on the left for the spine, anywhere in the spine, whether cervical, thoracic, or lumbar, If both movements are equal based on patient performance, you can conclude that there is what? Capsular pattern. And capsular pattern is what? Is an indication for what? Capsulitis or osteoarthritis or spondylosis. So you have capsular pattern description for the cervical, you have for the thoracic, you have for the lumbar. The most common thing here is that side flexion and rotation are equal on both sides. What about for shoulder? If the capsule of the shoulder is involved in the pathology and that is what is responsible for the pain, what you're going to notice is that lateral or external rotation will be the most limited movement displayed by the patient when you are doing active range of motion. Lateral or external rotation will be mostly limited, and that will be followed by abduction, and that will be followed by medial rotation. If you notice it in that sequence, then you can conclude that you have a capsular pattern for the shoulder. You can conclude that it is possible that in the shoulder there is capsulitis or there is osteoarthritis. The capsular pattern for the wrist is that what? Flexion and extension will be equally limited. And for the elbow is that flexion is more limited than extension. For the knee, flexion is more limited than extension. For the ankle, the capsular pattern is that plantar flexion becomes much more limited than dorsiflexion. Okay, patient will not even want you to attempt plantar flexion, or himself or herself will not want to attempt plantar flexion, but will still be able to do dorsiflexion to an extent. When you notice that pattern of movement restriction, you can conclude that there is capsular pattern in the ankle, and you can conclude that the underlying pathology is either capsulitis or osteoarthritis. So while Cyriax uses active movement and resisted active movement to detect lesion in the contractile structure, he used passive movement to detect lesion in the non-contractile structure. Then he used capsular pattern to detect lesion inside the joint or with the capsule. Now the diagram you're having in front of you, if you watch the diagram, there's vertical and horizontal line, and there are lines inclined at angle just as present on the diagram, and you notice some marks on the diagram. If you still remember your geometry in mathematics, the moment you have the same sign on both sides of the line, it means both sides are equal. So if you check the line where rotation is written, you see that they both have single line across, both on the right and the left. And that's an indication that rotation on the right is equal to rotation on the left. If you look at the line that describes side flexion to the right and the left, they also carry the same sign. So what does that tell you? It tells you that this patient is having the same amount of rotation to the right and the left, the same amount of side flexion to the right and to the left. And that is what we call capsular pattern. It's the capsular pattern for the cervical, for the thoracic, and for the lumbar spine. All right. So still talking about capsular pattern. If you try to carry out active range of motion for the shoulder in particular, what did I say? External rotation, lateral rotation will be the mostly limited movement, followed by abduction, followed by medial rotation. And if you get that, it's an indication that the lesion is coming from the joint. It could either be what? Osteoarthritis, or it could be adhesive capsulitis. Now, what about this? If you study this diagram here, right on this slide, number 17, if you look at rotation, you see that rotation to the left have a sign, but the one to the right do not have any sign. That means they are not equal. Rotation to the right and the left are not equal, and the same thing applies to side flexion. So that's a non-capsular pattern. So the pain this patient is having cannot necessarily be coming from the joints or be necessarily due to involvement of joint capsule. So we have to check the articular, where the contractile and the non-contractile and perhaps psychogenic sources of pain. So non-capsular pattern are obvious and capsular pattern are obvious. What you have to do as a student of manual therapy is to master what will be the capsular pattern for different parts of the body, the spine and the peripheral joints inclusive, so that when you are assessing your patients and you notice a pattern of movement restriction, you can say to your colleague or say to the patient, this is a capsular pattern and is merely indicating that your pain or discomfort is coming from the lesion. Now, another method of assessment based on Cyriax approach is to look for the end field, right? Cyriax use end field to detect the presence of impingements in a joint. There are other impingements in the joints in other parts of the body that you might not be able to get with the painful axe syndrome. I've described to you earlier on that impingement could be anything that is positioned inside the body that is now altering the normal position of the joint or is now affecting the movement, the normal movement of the joints. So how do we get there? We can use end field. So end field is specifically designed to detect impingement and to detect malignancy or extreme pain due to serious pathology inside the joint. But first of all, let us try and define what end field is all about. Then we need to know what normal end field that we all have, so that we'll be able to recognize abnormal end field and we'll be able to make diagnosis. Well, by definition, end field is the type of sensation that the therapist feel in his hand at the end of passive mobilization or at the end of passive movement. So if a therapist carried out passive movement on your shoulder, the kind of sensation that the therapist feel in his hand at the end of that passive movement of the shoulder is what is called an end feel. So the end feel is a type of sensation or feeling which the examiner experiences when the joint is at the end of the available passive range of motion during assessment. For example, in the diagram you're having on the slide, you can see the therapist doing a bit of elevation of the shoulder. So what does the therapist feel in his hand at the end of the movement? Does it feel soft? Does it feel hard like bone? Or does it feel somewhere in between soft and hard, which is what we call firm? All right, that's what we call an end feel. All right, the end field can reveal a great deal about the nature of various pathological conditions going on in a joint. But before we look at that, we need to know what are the normal end field and what are the abnormal end field and what do they really diagnose. Well, let's talk about the normal end field first. One of the normal end field in our body is what is called bony end field. Where do we get bony end field? Bony end field, you can feel that if you try flex your elbow and use your other hand to bring the flex elbow to extension, full extension at the end of the range. You got to remember that end field is associated with the end of the range movement. So if the elbow is now brought into full extension, what will the therapist feel in his hand? It feels bony or hard. So that's what is called bony end field. So bony end field is common with elbow extension and with knee extension in the body. That is normal. Nothing is wrong with the joint. But let us assume that the therapist is attempting extension of the elbow, and before you get to the end of the range, he felt hard and bony before the end of extension. Then that means something is blocking the joint. That means there's an internal derangement. It could be calcific tendinitis, it could be myositis or cervicans. All right, because that bony end field is only normal at the end of range of extension of the elbow and the knee. So another normal end field is what we call soft tissue approximation end field. Where do we get this one? It comes with elbow flexion, as you can see in that diagram. So with the therapist demonstrating flexion of the elbow, if the therapist push the elbow to full flexion, what will he feel in his hand? It's going to feel very soft, right? In the therapist's hand. So that kind of end field is described as soft tissue or approximation end field. And it is only normal when it comes at the end of flexion of the elbow and the knee. If it comes before the end of the movement and there's no movement again, then definitely there's a pathology going on inside the joint in form of internal lesion or internal derangement If you cannot decipher it physically, then you ask the patient to go and do a radiological investigation so that you'll be able to know what is blocking the joint. So the second normal end field is soft tissue or approximation end field. We've talked about bony or hard end field. Now, the third normal end field is what is called a firm end field. A firm end field is not as hard as bony and is not as soft tissue end field. And that's what you find, for example, if you use your left hand to put your right wrist into extension. So at the very end of extension, what do you feel in the left arm? It feels firm, not as soft as the flexion and not as hard as the boning. So we say that's a firm end field. And that's a normal end field for other parts of the body that we have not described, not just the wrist. For wrist, firm end field is normal for all the movements. For the shoulder joint, firm end field is normal for all the movements. For the elbow, we've talked about soft tissue and hard. For the wrist, I said firm end field is normal. If you go to the hip, firm end field is normal for all the movements. For the knee, we've talked about soft tissue and approximation. If you go to the ankle, firm end field is normal for all the movement. You are expected to know this as a student of manual therapy or musculoskeletal physiotherapy. So the three normal end fields are what? Soft tissue or approximation, hard or bony end field, and firm end field. Now we want to talk about the abnormal end field. What are the abnormal end field? The abnormal end field, there is a spring or a bound. As the therapist is attempting the passive movement, there's going to be a pushback into the hand of the therapist in form of a spring or cachete before the end of the range will be reached. Whenever a therapist experiences something like this, this is an abnormal end field. And the most common example of springy end field happens in meniscus lesion. If there's meniscus lesion and the therapist is attempting to put the knee into extension, patients automatically push back into the hand of the therapist in a springy manner or in a springy manner. And that's an indication that there is a meniscal tear. So that's an abnormal end field. Another abnormal end field is when a therapist is attempting to evaluate the end field and suddenly the patient feels so much discomfort and withdrawal is part of the body from the therapist to resist further motion. So that will be called an empty end field. That is also abnormal, and it only happens in cases of extreme pain due to cancer or neoplasms. So while soft tissue or soft tissue approximation, hard or bony and firm end field feel normal, they are normal end field, springy end field, empty end field, and some other ones that are less common than these five are abnormal. You're going to see the list of many other end field on this table. Although the five common ones are the soft tissue, the hard, the firm, and then the abnormal one, we have the springy, and then we have the empty. But there are also others normal and abnormal end field that has been described in the literature. And I've told you that normally for the shoulder, in all directions is supposed to be firm. But if the therapist attempts elevation into abduction and towards the end of the range, there's a springy end field, a pushback into the hand of the therapist, then that shows there is a pathological situation in form of impingement or lesion around the joints, right? Normally, whenever there's subacromial bursitis, you see the acromion and the bursa under the acromion colored blue, if it's inflamed, subacromial bursitis, and an attempt is made to go from abduction into elevation, there will be a pushback into the hand of the therapist in a springy manner. So if there's subacromial bursitis, there will be a springy end field with abduction rather than firm end field. And that's an indication of impingement coming from subacromial bursitis. All right. Now, I haven't dealt with Cyriax method of assessment. Can we have a quick recap? Active movement and Isometric muscle contraction is used for contractile structure. Passive movement is used to assess lesion due to non-contractile structure. Capsular pattern is used to assess lesion due to joints or capsular involvement. And end field is used to assess lesion due to internal derangements or neoplasms or extreme causes of pain due to cancer and all that sort of movement. Okay. Right. So what are the methods that Cyriax advocated for management? We have deep frictional massage is one of the methods that Cyriax advocated for treatment. And I know you've had a tutor on deep frictional massage, but simply put, deep frictional massage is a connective massage that was first described by James Cyriax, and it involves putting it involves the use of fingers, one particular fingers, or putting one fingers on top of the other, placing it across the tendon. It's particularly used for tendons and ligament injury. So placing it across that tendons or ligaments to carry out a repeated transfers or circular movements carried out for a short period of time that can help to stimulate pain modulation and reorientation of the fiber. All right. The main purpose of deep frictional massage is to maintain mobility whenever there is adhesion, and is to prevent adherent scars from forming onto the tissue. All right. How often should deep frictional massage be applied? The frequency normally would depend on the type of injury that the patient is having. If the injury is acute in nature, then the treatment will be very light and it will be carried out every other day. Generally, frequency of frictional massage is every other day. So you carry out the treatment today and you allow the patient and the soft tissue to recover tomorrow, so that day after tomorrow, patient will have to come for another treatment, especially when it is very acute. By the time it gets chronic, if there is time, treatment can be repeated twice in a day. It could be a day rest, and then the other day will be a period of time for another treatment. What could be the duration of frictional massage? If you're dealing with a small area of lesion, the whole time required for deep frictional massage should not be more than 5 minutes. But if you are dealing with a large area, then you can divide the large area into 5. If you divide the large area into 5, the first portion you can carry out frictional massage for 2 minutes, the next portion for 2 minutes. So for a large treatment area like that, you end up spending like 10 to 15 minutes. But one treatment session per se should not last for more than 2 to 5 minutes. All right. Intensity is how deep should the pressure be. Generally, when you're applying frictional massage treatment, you should start with light pressure, at the early session of the treatment. At the very early session of the treatment, the friction should be very light. And with more and more treatments, you can increase the depth of the friction that is applied across the tendon. So that means intensity should be very gradually increase. The depth of the friction should be very superficial at the initial stage. Then as time goes on, increasing depth of the friction could then be applied during the treatment. And studies have shown that application of light pressure, gradually transiting to deeper pressure, is more effective than applying deep pressure at the start of treatments with deep frictional massage. And the effects of deep frictional massage will include pain reduction. It will reduce pain. I told you it's a modality of treatment. When you think of lesion in the tendon or ligaments, then you might want to use deep frictional massage. It reduces pain via pain modulation at the level of spinal cord by causing spinal pain gates closing mechanisms, inhibiting transmission of pain through by inhibiting transmission of pain through A delta and C fiber, and encouraging transmission of pain via stimulation of mechanoreceptors and activation of A beta fibers. So the pain is gated at the level of spinal cord. The impulses could even get to the brainstem and cerebral hemisphere and activate descending inhibitory mechanisms where enkephalins and endorphins, dynorphins are released, and pain modulation take its effect. Deep frictional massage could also lead to stimulation of fiber orientation, all right? That is necessary for tendon and ligament healing. It's also useful for prevention and removal of adhesion and formation of local hyperemia, which will cause more flow of blood to the affected segment. So frictional massage is one of the techniques of treatment used by Cyriax. The other techniques of treatment used by Cyriax is joint mobilization and traction. Joint mobilization and traction, which could be in grade A, grade B, or grade C, according to Cyriax. Grade A, joint mobilization could be applied at the earlier stage of the lesion, and that is applying passive joint mobilization, but not to the end of the range of movement before it is repeated. So that could be a choice of treatment at the very early stage of managing a condition with Cyriax. Grade B, in terms of intensity, is carrying out passive joint mobilization to the very end of the range of movement. And grade C is actually manipulation, and that is delivering high velocity, low amplitude thrust to the joints. Description of this is beyond the scope of this introduction, but in our subsequent presentation, when we'll be talking about Cyriax application to different joints in the body, we will be able to show you, I will be able to show you how each joint is mobilized and manipulated based on Cyriax approach. Now, what are the effects of this peripheral joint mobilization that Cyriax advocated? There's mechanical effect, there's neurological effect, and there's nutritional effect. Mechanically, it's improved mobility of the joint. So if a joint is hypomobile and you mobilize it using Cyriax technique, you'll be able to increase the mobility. It's also useful to maintain extensibility of soft tissues and to maintain the strength of articular tissue. On the neurophysiological basis, I've talked about the fact that application of Cyriax during friction or during passive joint mobilization could activate the spinal gating mechanisms at the level of spinal cord and activate descending inhibitory pain modulation mechanisms from the brainstems and the higher center, and that will lead to relief of pain and resolve of muscle spasm. But there is also a nutritional effect because many of the joints, particularly the synovial joints, the anatomical structure around the joint derive their nutrients, most of their nutrients from the synovial fluid. And the more movement of the joint, the more will be the rate of diffusion of this nutrient from the synovial fluid into the neighboring structures in the joint. The contraindications to using passive joint mobilization of Cyriax include if the injury is too acute, like less than 72 days, and if the injury is not healing, or if there's infection of the bone, otherwise known as osteomyelitis, if there's osteoporosis, that's a decline in the bone mineral density, spinal hypermobility, if there's a tumor, then Cyriax cannot be applied directly over the parts of the body that is carrying tumor. And then if there's rheumatoid arthritis, in situation of rheumatoid arthritis, all the connective tissue around the area you are treating might have been compromised. You know, it's a systemic autoimmune disease, so it doesn't matter where the patient is feeling the pain, there could have been compromise of the integrity of soft tissue elsewhere in the body. So we really have to be careful when you're applying passive joint mobilization or deep frictional massage. So Cyriax uses deep frictional massage, it uses passive mobilization as treatment technique. He as well uses active movements to treat his patient in form of isotonic exercises, isometric coordination, even utilizes electrical stimulation. And finally, Cyriax also carried out traction and injection. Now, I said the detail of all this technique is beyond the scope of this introductory lecture to Cyriax. In our subsequent training, advanced manual therapy, we'll be able to mention how these specific techniques are used to treat different parts of the body. So that's where we're going to stop today. You can start applying this technique in managing your patient. And if you record any success story, please share with us so that other people will also benefit. Thank you for listening and see you at another time. Bye-bye.